think we're going to get started now. Good afternoon in the East and good morning in the West. My name is Richard Frank, and I want to welcome you to Brookings today for a discussion about the opioid epidemic and its impact on labor markets and employers. Today's program will begin with a fireside chat featuring Director of the White House's Office of National Drug Control Policy, Dr. Rahul Gupta, and the Wall Street Journal's Julie Wernau. The fireside chat will be followed by a panel discussion that will include Dana Lariviere, President and CEO of the Chameleon Group, Dr. Tisamarie Sherry from the Office of the Assistant Secretary for Planning and Evaluation at HHS, and Kyle Zimmer, the Director of Health and Safety and the Members Assistance Program at the International Union of Operating Engineers, Local 478. Let me now start the program for real by introducing our guests. Dr. Rahul Gupta is the first primary care physician to serve as director of the Office of National Drug Control Policy. In addition to practicing as a primary care physician for 25 years, Dr. Gupta served under two governors as the health commissioner in West Virginia. As the state's chief health officer, he led the opioid crisis efforts, which, as you know, hit particularly strongly in West Virginia. Today, he oversees the federal government's response to the opioid epidemic as in his role as director of the National Office of National Drug Control Policy. Julie Wernau is a reporter that writes about health and medicine across the United States at the Wall Street Journal. She's in the Health and Science Bureau in New York and covers stories that reveal the on-the-ground impacts of health policy across the United States, with a particular focus on the opioid epidemic. Following the fireside chat, we'll have a question and answer session at the conclusion of that. And so if you have questions, please write them down on a note card that's provided either at the back of the room or will be provided to you upon request. The virtual audience can submit questions through the event landing page. So without any further ado, please join me in welcoming Dr. Gupta and Julie Wernau.
Thanks. Good to see you.
Good to see you as well. Thank you.
So I thought, generally as a journalist, I feel like we spend a lot of time writing about sort of the hopelessness of the opioid epidemic. And so I was excited to come today to be able to talk a little bit about recovery, which is one of my favorite topics and is possible. So what does it mean to have a recovery-friendly workplace? And what are you doing to make that possible?
Great. Thank you, Julie, for that question. And I start out, first of all, thanking Richard and thanking the Brookings for having us here today. Thanks to everyone here and in virtual world. I tend to remain optimistic because of a number of reasons. One of those reasons, a big one, is recovery. Recovery itself is the equivalent of the hope we have for individuals, hope we have for society, for the country. We know there's tens of millions of Americans today in recovery. 60% or more are gainfully employed, and recovery, the people in recovery are some of the most dedicated, hardworking people. I know that personally also because I have people in recovery working in my office. So that's the first thing. But then we want to think about what does recovery-ready nation means. That means not just individuals, but also recovery-ready communities, recovery-ready businesses. And what does recovery-ready business really mean? It means, in a very simple way, becoming part of the solution. For too long, I think systems across America, including workplaces, have been part of the problem for people who are suffering and going through addiction or maybe in recovery. And I say that because that's kind of what a lot of our data shows. Data shows that of the 46 million Americans who are suffering from substance use disorder, when you ask them, why aren't you getting treatment? Because less than 1 out of 10 are getting treatment. One of the big reasons is they say, well, more or less, I don't want to lose my job. And if I somehow disclose or seek help, it's going to interfere with my job. So the ability for businesses to think about that, understand the productivity benefits of this, but in so many ways, other benefits of having recovery-friendly workplace is a game changer for the nation.
You know, it's interesting you talk about treatment because, I mean, we know that the opioid crisis is costing businesses and the economy just, billions of dollars, and it's not only from these lost workers, but it's also in health insurance costs. So large employer plans are spending 3 times what they were like 15 years ago. But like you said, I mean, meanwhile, less than 10% of people are actually getting the gold standard of treatment, which is medication. So what can we do to make treatment more accessible, particularly evidence-based treatment?
Yeah, so a lot of things have happened which are historic in this administration. One of those is, as the president had called out in his State of the Union a year and a half ago, 2 years ago, of wanting to remove barriers to treatment. And then Congress acted and the president signed into law something called the Ex Viva Removal, or the MED Act. That now increases our ability for doctors and prescribers to go from about 129,000 providers to almost 2 million to be able to prescribe treatment for opioid use disorder. What does that mean? That means that when I began my career in a rural town, I could write somebody as many Percocets or Lortab or OxyContin as they needed with a DEA license. Yet when they come to me and say, well, doc, I think I have a problem, I'm taking too many of these and I can't get off, means opioid use disorder, I could not treat them with a lower scheduled drug because I had to go get an extra license for that. These are the artificially created barriers that we had in the system. As we are removing them, it's going to be really important that of all the institutions, businesses are supportive of that, because we have, for instance, if you look at the pre-pandemic to pandemic level, up to 26% of workforce loss was attributed to opioid crisis. That's a lot of people, working age, being lost to business. We also know that it's the #1 cause of death for people, young people, working age people. As you mentioned, as per the Joint Economic Committee in Congress, in 2020, we lost $1.5 trillion of economy in a year. 1.5 trillion with a T. Guess what? Russia's GDP in 2020 was 1.5 trillion. We're losing that amount of economy every year because we're losing workforce.
Speaking of lost workforce, a large number of people who are in recovery at some point in time find themselves incarcerated. And it seems that that's a huge part of the lost workforce is people who have a criminal record, have trouble getting back into the workforce. How can we reintroduce people with criminal records into the workforce safely?
So that's a great question, because we know that at least 2/3 of people behind the wall today in all the prisons and jails across America have a disease of substance use disorder, at least one disease. That's 65%, at least. So one way to do it, and this is exactly what CMS announced yesterday, so this is very timely, is to offer states the ability to apply for Medicaid to incarcerated populations in jails and prisons for states 90 days before discharge. So what that means is, because you have so-called quote-unquote captive audience, let's go ahead and treat them. Because when you don't, guess what happens? People will be released, and the likelihood of them overdosing and dying goes up by 40 folds, according to some studies. And if they're not dying, they're going to be reincarcerated at high rates. Either way, it is not a smart policy to not treat people when they're incarcerated. And we're doing the same thing in federal correction facilities as well, coming soon. So the notion is, let's get people to help while they're incarcerated, while also working to deflect people not to be incarcerated in the first place, and then work for drug courts and other aspects. And then find people the opportunity, the economic opportunities that allows them to be successful. When we do that, we're going to have a tremendous impact on not just the justice involved individuals, but generally anyone in recovery.
I mean, it seems that sort of one of the tension points here is that, we all want recovery. We want people in recovery, right? But we also want workplaces that are safe from the harms of people who are in active substance use disorder. And particularly in some industries, active drug use, is grounds for firing an individual. So how do you support people who are still seeking recovery while keeping them in the workforce?
So that's a great question. So let's first start with this basic factual sort of thing, which is, if you have people who are in recovery or who are relapsing in recovery that you're able to capture early in business, you're actually reducing your turnover. And having been in business school, I know what that impacts your business. Then you're also increasing your productivity. Your health insurance costs are going down because a lot of the large insurers, as you know, are self-insured. And then the workplace injury costs are also going down. So it makes sense, right, to figure out how to do this. Now, people who run businesses oftentimes really get that. So I was speaking to Governor Sununu, New Hampshire, and he began to describe to me, look, he said, I run a business. As someone who was relapsing, I have that person connected to another person who was in recovery within my business, and they then began to help each other out. They began to look after each other, check the early signs of trouble, and support each other. And as he was talking, I was thinking, he's talking about peer recovery network. He's talking about a recovery-ready place. He may not look at it that way, but that's what he's talking about. And he's doing it not only because he supports recovery-friendly workplaces, but he's doing it because it makes sense from a business standpoint for him. He's a good business person. So this is the thing about recovery, is having recovery-ready workplace also means having the elements available that are helping to help people take off that stress of your employer finding out that you're going to get in trouble, so you're going to now either not show up or have a problem with productivity. If they know that they can go to their supervisor and say, here, this is what's happening, and supervisor, that non-judgmental way, will connect to other people similarly, that's the best way for that business to move forward.
It's interesting. Brookings did quite a lot of research into this, which I read thoroughly. And one statistic that I found fairly troubling was that 98% of mid and large employers have these EAPs, which employee assistance plans, which everyone's familiar with. And they said that only 4% of employees are actually taking advantage of them. And that made me wonder if part of the problem here is that people struggle to trust their employers with something like substance use, and if there is the EAP even working? Is it something we should throw out? Is there a better way, or should we be spending more time trying to gain the trust of employees, and how do you do that?
As with any program, and business leaders understand that than anywhere else in the world, which is, for your program to work, you've got to have buy-in. You got to have people. I mean, I promise you that I say the same thing to my friends who are doctors and in healthcare hospital systems. I say, if you're not seeing people with addiction, you're probably missing those patients because they're in your practice. We have 46 million people, 15% of the American population, and I'm talking about only those over 12, that suffer from addictions. So if you're not seeing them, it's your problem because they're there. I would say the same thing to businesses. If you think that you do not have anyone in recovery or with substance use in your business, you're either too small or you're mistaken. And why small? You might be the only one running the business. And the point behind that is that when we have these employee assistance programs, they really are designed for that purpose, to help people, to have the stigma be removed, to be able to get the help when you. But you also have to create a culture around that. The culture has to be one that is embracing, that's destigmatizing, and it's one that encourages people to seek out. Otherwise, what you described to me is basically the definition of failure of a program.
It seems to me from talking to employers that they're not really sure how involved they should be in their employees' substance use and recovery. In a recent survey by Forsmarsh found that employees who reported higher levels of trust and psychological safety within their organization were more likely to feel comfortable going to their supervisor and talking about substance use. And this was particularly important to millennials and the Gen Z generation. I mean, how involved should employers be in the recovery of their employees?
So I think I will try to parallel as much as possible the healthcare industry. We have older generation physicians and younger generation physicians, and younger ones are much more adaptive to get treatment to people. Same way we have now employees, the millennials, the Gen Z employees. They are going to be looking for employers to take their talent where they will feel the management is more receptive to the challenges that they're facing. That includes substance use disorder, that includes mental health issues, that includes other social challenges, sick leave, parental leave, family medical leave. You know, the president has been very clear about this, as he has talked about, being the champion for people to be able to get paid sick leave, family leave, to be able to just help support people. I think it's important for us to think about it that way, because the next generation in the workforce demands that of us, and we must deliver.
So paid sick leave, you're saying that you think that paid sick leave is a really important part of the process. I think any employer that has employees who are in physical labor is particularly hard hit by the opioid crisis, and folks, who are working physical jobs are most likely to be prescribed opioids, and they're also often less likely to have the paid time off that they need. And so that kind of creates this vicious cycle where people are taking more and more opioids in order to continue working. And these same industries have huge worker shortages. So obviously it's a really complicated problem, which we expect you to solve today. But I mean, how can you give these people the time off they need to recover from their injuries while also addressing labor shortages?
Right. I think there's a few ways to do it, and there's clearly ways to do it. One of those, if you think about it, we as a nation have figured out how to be really a pill nation, right? Pill nation. So if there's a problem, and I'm one of those people in the profession, if there's a problem, we have a pill to solve that, no matter what it is. We don't really give enough opportunity for social, emotional space and learning and time. And therefore, we've begun this, anyone who's in, having a pain probably needs an opioid. And we began prescribing, and we are here today when America is dying every 5 minutes, ultimately as a subsequent consequence of that type of trend. We need to be thinking about what are those other alternatives, non-pharmaceutical alternatives, non-opioid pharmaceutical alternatives to help people when they go through pain. Sometimes it's a matter of healing from the prior injury. Healing of tissue takes time. We know that opioids aren't the best pain medication treatment, but because healing has to occur. So I think allowing that amount of time for people to heal up if they are going through that, and at the same time having those teams that can actually support the work at the same time. That's one of the ways to make sure that we are, creating that backup of the workforce when someone does go off, rather than attempting to rush them back into workforce so their primary injury never gets healed. And then we are surprised when people younger and younger are filing for disability and having trouble because they can't do that work any longer. So I think if we look at the human body as as one that we need to invest into to ensure that we have longevity behind that, we allow tissues to heal every time that injury occurs, we're going to get farther.
Are there supportive policies that you think could help these people to have that time that they need to have their injuries heal, and also support the employers who need those folks in the workplace and are struggling with shortages?
I think, again, paid sick leave is really important. I think having a close relationship, the employer-employee relationship, where there's a trust built in the system, so that that paid sick leave and people feel comfortable into working with their medical provider and their employer as partners. And that's also important from a litigation standpoint too, because we see that same thing in medicine, where some of the docs who often get in trouble are the ones the relationship isn't as good with their patients as it could be. But also, I think the policies of having a workforce alternative available, so the employer doesn't depend on just that one employee for that work, and that work either gets shut down or that employee has to come back early. That net zero effect that happens is often detrimental to both business as well as the employee in the long run.
Opioid addiction recovery doesn't just impact the employers themselves. There was an interesting study that RAND did where they actually found that women are particularly impacted by a partner or someone in their lives that is struggling with opioid addiction. And so I'm wondering, is it the employer's job, or is there some way to support the people who are the supporters of recovery, who it turns out research shows are really the most important people in the room?
Yeah, I think you bring up a real good point, Julie, which is when someone's suffering from addiction, substance use disorder, what kind of supports they need and what are they getting today in the United States? So we have 46 million Americans who are suffering from substance use disorder. Less than 1 out of 10 are getting treatment. We have 20 plus million Americans who are in recovery successfully. And yet we often talk about the supports. So it's really critical for that employer-employee relationship to consider what else is going on in the homes of that individual. If the support is needed for that person, we're talking about family leave, family medical leave, and other aspects to provide that support to a loved one is really important. I can tell you stories after stories of well-placed individuals that I've gone through in my career who have either lost a child or loved one to addiction because they did not feel empowered to just take time away from job to go help their family member. And that happens every single day in America, because that's the culture we have. We have a work culture in a way that we do sacrifice our own family members, and until we realize that person's no longer there. So there's some real consequences that happen because of this type of thought process that we have right now.
I wouldn't want to leave this conversation without asking you about harm reduction, which I know is sort of a big policy push from the Biden administration and in your office. What is harm reduction, and what role does it play not only in the workplace but for the workforce at large?
So harm reduction is basically very similar to what we're talking about, which is meeting people where they are. So when we talk about smart work policies and recovery-ready places, we know there's quite a bit of benefit to be recovery-ready as a workplace, as a business. Harm reduction is very similar approach, which is if you meet people where they are in their journey, you could actually not only build trust, provide people the help they need, and then ultimately save lives. For instance, think about naloxone. And for the first time, obviously another historic first in this administration, the federal government is embracing harm reduction in terms of evidence-based, data-driven, cost-effective policies, mostly three. Naloxone, an antidote for opioid overdose, which is killing like 7 out of 10 Americans today of the overdoses that are dying. Second is the drug checking or test strips, and the third one is syringe service programs. But I'm gonna give you an example about naloxone. Because 7 out of 10 people are dying from opioids like fentanyl, if we have enough naloxone, you can save those lives and then connect them to treatment. So we're talking about 70 to 75 to 80,000 people that could be saved right now. Most of them, if not every one of them. And the fact is then what do we have to do with naloxone? Well, we need to have it available like a fire alarm, like a defibrillator, like a smoke alarm in homes. If we make that available, whether it's in schools, businesses, restaurants, or people having them, we're gonna save a lot of lives. We know that, the data shows that. But this is why it's important right now, is to have harm reduction policies ready, available, and resourced. I mean, President has proposed $46.1 billion budget. 57% of that goes towards things like prevention, harm reduction, treatment, and recovery. The idea and the notion behind that is that we must meet people where they are, support, and make sure that we're helping while we're addressing the supply side as well.
Let's say you're an employer and you really want to have this recovery-friendly workplace. What's the first step? What's something that you could say to your employees to, first of all, signal that you're friendly to that, and secondly, that you're serious about it? And can you sort of just give us your vision of what that workplace, that ideal recovery-friendly workplace would look like?
Sure, that's a great question. I think the first thing that has to happen is the employers need to have a conversation in a way that's safe. Employees feel comfortable in sharing their own stories, because oftentimes the EAP programs, others, there's a stigma that what if my employer finds out? So we have to create the space where employees who may be in recovery may step up and want to become leaders within the employment workforce place, working with the employer close by to help other people. And then have policies within which will help others self-identify when they need help, be able to reach out for help, have others there who will support their recovery as well as their relapse, and be able to get there together. And the way you can judge that is, the amount of people who are coming to you, and once you become a recovery-ready workplace like this, in an ideal way, is where a lot of the people are gonna look at to be able to work, because it is not only recovery-friendly at that point, you're also friendly to the needs of people, especially when we're talking about millennials and Gen Z. You're looking after the interests, and it really becomes a harmonized approach to work environment where you're taking care of people as part of their family. They feel that you and they are part of the same work family. And that helps to narrow the bridge between the employer and employee, but also I think it helps in so many other ways to boost the productivity, reduce the turnover, reduce the healthcare costs, as well as reduce injuries, workplace injuries that often happen.
I think anybody who works in a large company is sort of familiar with the sort of checkbox exercise where, your company says we're against sexual harassment, and then you do this kind of training and you check it off and don't really feel, that it's actually doing anything. How do we avoid this kind of turning into that kind of checkbox exercise,
Right,
in which the employees have sort of a voice in what a recovery-friendly workplace looks like?
I think the first thing is being explicit about it. Being explicit to the workforce that if you need help or you're looking for, we're here. We're here for you. Also developing champions, recovery champions within the workforce. So there are those that others can go to at workplace without necessarily having to go through the entire chain of command. And those people will help each other. Because one of the things you'll see is that peer recovery network tends to be one of the strongest networks, because people are there to help each other. And when you do that, what you find is not only the benefits I mentioned, but you find some of the most dedicated, hardworking employees. And they recognize when the employers and the management is supporting recovery, that train goes in both directions. The employees also recognize the value of that place and the employers, and then you'll get some of the most dedicated people you'll ever see.
Well, thank you for the conversation. I know we have a lot of questions from the audience, and I have a couple that were submitted sort of in advance, and so if you don't mind, we're gonna
Let's do that.
ask you the tough stuff now. That's not
Yeah.
from me. So
You're not soft.
I try. So this actually is a great question, especially because of, I know there's a lot of debate around this. There's actually a story in our paper today about it. Someone asked, how could telehealth play a role in recovery-friendly workplaces?
That's a great question, and here's why. It used to be where, for employers, why it's even bigger pitch now for recovery-ready workplace. And I also want to just put a plug for, our Department of Labor has done a fantastic job of having Recovery Ready Hub available on the website. Just wanted to mention that. This is the way that the federal government is moving forward to support businesses. So you would give person time off, and they would go and obviously go in a waiting room for my office and wait, and then all of that. Now you have an appointment, let's say 12:30 to 1, and if employers allow, people can go into a safe space, take that appointment, and come back and work. So telehealth has made, it's probably one of the best recovery-ready or recovery-friendly businesses could ask for from just an instrument of saving time, saving energy, and money on both ends. And you'll have happier employees at the end of the day because they're able to get their appointment quick and without strings.
Okay, here's the elephant in the room. How can we work to destigmatize SUD, substance use disorder, in the workplace?
So let's think about this, right? I keep seeing the numbers, 46 million Americans, 20+ million Americans in recovery. That's a large number. I think we're getting to a point where whether it was cancer or HIV or you name the disease, we've been through these situations where we have worked ourselves slowly to destigmatize diseases. It's time that those of us, first of all, who have gone through recovery or are in recovery need to be talking about it, having that conversation with their managers to talk about, hey, here's my story. Would you like me to, state and share with anybody else? We also think that one of the ways to destigmatize is to mainstream treatment, to mainstream the ability of employers to have those recovery-ready workplaces, as we've talked about. I think it's going to take all of us. At the end of the day, it's not the job of one person as opposed to the HR manager or others. It's everybody's job in workplace. But in the larger sphere, some of the areas that are very stigmatized includes healthcare, if you believe it or not. Healthcare is not immune from the stigmatizing effect. So we are taking that approach in the Biden administration to making sure that we're approaching both healthcare, whether it's curriculum, whether it's trainings, whether it's removal of the extra barriers that the President has called for and has happened, or making treatment, normalizing treatment into primary care. So we continue to work. And it's a long-term aspect. It's going to take us all to do it, but it needs to happen quickly.
I'm just going to ask really quick, do you see the removal of the X waiver as a part of that destigmatization of healthcare? Because a lot of doctors have said to me that for some of them, the barrier is not the X waiver, it's the hospital system they work for, it's the clinic they work at. They don't want people with substance use disorder there.
Yeah, so I look at X waiver removal as necessary but not sufficient. It was an important part that was stigmatizing in nature because it gave excuse to healthcare systems, doctors, hospitals, to not treat people. Now, one of the things you do is you remove the excuse. And then the implementation of the removal of X waiver is what's tricky. We have to make sure that doctors are writing the prescriptions, pharmacies are filling the prescriptions, distributors are distributing the drugs, and manufacturers are manufacturing it. And the reimbursement systems align with that. So at the end of the day, it's entire implementation that has to happen. But one of the enabling factors of stigma was the X waiver. And removing it is going to be a really important piece.
How have ONDCP's priorities changed since the rise of fentanyl and other synthetic opioids?
Yeah, so I think one of the things that we should talk about also is this change that is happening in drugs. You know, what has happened a little bit more than the time of the pandemic, but included is the nature of the drugs, the way we buy drugs, the way we sell drugs, and the way we consume drugs. So that includes, when I say nature of the drugs, where the era of large volume-based organic plant-based drugs is waning. Not over, but it's waning. And the era of the small, lethal, synthetic drugs is coming in, and it's becoming a global threat. We are now, the type of drugs we're seeing now much more fentanyl, but much more fentanyl in other forms like pills, counterfeit pills. Purchase is happening, sales are happening online oftentimes. You don't have to go to a corner to find someone. You can order them in the palm of your hands and get some of the most deadly drugs. And you know, one of the other pieces of this also is the cost. These are profit-driven aspects of this, so it becomes. And then you always have to think about where is fentanyl going. So the reason we declared xylazine an emerging threat, an animal sedative last week, is because now fentanyl is being mixed in with xylazine, which is a terrible drug for humans, and that is happening. So this is evolving, and I think it's really important for us to understand this is not your grandma's drug crisis. It's a very different one, and we need to keep up with that.
We have a difficult question here. How do you propose to incentivize firms to become recovery friendly, given that those suffering from opioid use disorder do incur higher healthcare costs? Firms generally won't do this out of the goodness of their hearts.
So that's a good question, because that is true. And while many will do it because they just know that's the right thing to do, and or it will help them with their bottom line, others may be more difficult. There's ways of doing it. First, if you go to the Department of Labor's Recovery Ready workplace, you can actually put your firm's data, and you can find how much money you're losing because of not being recovery ready. So there's a way to test that yourself. Also, I think what we can do, and when I meet with city mayors and others, I often say, you can incentivize having some type of a competition within businesses in your jurisdiction to encourage recovery ready funds. There's a way to do it where we are always asking elected officials to think about how do you incentivize or at least have competition within businesses going towards where everybody will first know what it is, and secondly, they'll compete to make sure. Because the fact is, again, we have a large population of the 100,000 plus people that die. Majority of those are between 25 and 54, at a time where we have the lowest birth rate on record in the United States. So if you're looking for longevity of your business, if you're not a flash in the pan, think beyond election cycles. And we're going to have a major problem from a workforce standpoint. And that's why it's important to think that way and make sure that we are becoming recovery ready.
Somebody pointed to the fact that drug-related deaths keep rising. Do you have any ways that we could do more to prevent opioid addiction? So prevention.
Yeah, so one of the semi-good news is that we have now seen a flattening or decline for the last 8 months by small numbers. Clearly, it's not enough, and we have to do more. I think prevention is really important, and it is the best return on investment of taxpayer dollars, if you think about it. So just about 2 weeks ago, we announced a social media campaign for youth on knowing the effects of fentanyl using naloxone. We're also working with Department of Education right now. We've held several webinars, 1,000 plus individuals and school district representations coming, where we shared the amount of federal resources that are available, but also what can be done to think about prevention in schools, K through 12, but also at collegiate level. I think it's going to be very important that we focus on prevention and also mental health and substance use overlap, because there's about a 50% both direction overlap. And we know that whether it's young adult suicide or dying from drug poisoning, these are both really important reasons for the reasons we're losing young people today.
Well, I know I promised to get you back to the West Wing in time, and I will keep that promise. Thank you so much for having this conversation with us today.
Thank you so much, Julie. Thank you for having me. Thank you, everyone. Appreciate it. Thank you.
Let's get the panel up. Welcome. This is our panelists. Begin with some introductions. I'm going to start on the far end. Dana Lariviere, as I mentioned, the co-founder of the Chameleon Group, an outsourced business development firm and call center located in Dover, New Hampshire. Mr. Lariviere is a technology executive and entrepreneur with about 30 years of experience, both domestically and internationally. Chameleon was an early adopter in New Hampshire, Chris Sununu's recovery-friendly workplace initiative, which you heard about from Dr. Gupta. And really, the Chameleon Group serves as a model for that. Dana is a proud member of Governor Sununu's workplace-ready recovery-friendly workplace advisory council in the state of New Hampshire. Next to Dana is Dr. Tisamarie Sherry. She is a health economist and an internal medicine physician who is currently serving as Deputy Assistant Secretary in the Office of the Assistant Secretary for Planning and Evaluation at the Department of Health and Human Services, also known as ASPE. She leads the Office of Behavioral Health, Disability, and Aging Policy, which conducts research and coordinates policy across the department in the service of improving the health and well-being of people with substance abuse, mental disorders, and disabilities. Kyle Zimmer, next to me, is the Director of Health and Safety and the Members Assistance Program at the International Union of Operating Engineers, Local 478 in Connecticut. He is certified as an OSHA Safety and Health Specialist and leads Local 478's Member Assistance Program. He serves on a variety of task forces and committees, including the Opioid Task Force for the North American Building Trades Union and the State of Connecticut Workers' Compensation Advisory Board and the Opioid Settlement Advisory Board, which is deciding what to do with the opioid settlement monies. So, you ready?
Ready.
Okay. Let me begin by observing something that you've heard about several times already today, which is that on a good day, very few people with an opioid use disorder get treated, 20% tops. And even among those who get treated, they don't necessarily get treated with the things that are most likely to get them better, nor do they get the support and background help that they need to really make recovery highly likely. Can you, each of you, speak to the role of employers in sort of augmenting efforts to try to increase access to care, how organized labor goes about it, and how policymakers sort of take it on? Why don't we start with Dana?
Yeah, thank you very much. I think great topic for discussion today. I don't know anybody anywhere that isn't touched by this problem. So if you start with that as a business owner, you look at how can I help, what kind of things can I do? Gainful employment, viable employment is huge. It's sort of the base for anybody that's in recovery. It helps to build their self-confidence. It helps to reduce their reliance on other resources, but it also helps to unlock resources that might be available in the community. And what we do as an organization is we have a network of organizations that we work with to be able to connect people. We look at it very much as any other sort of health crisis. And how would we address a health crisis with any other employee? We try and get them help. So I think from our perspective, understanding and recognizing that the problem is real, it's there, whether you want to deal with it or not, and also understanding that whether you know it or not, there are people in your organization that are suffering from it or have relatives that are suffering from it. So having a plan and being able to work with that is really key and a fundamental building block for an employee that's in recovery.
Tisa, why don't you give us the policy angle?
Sure. So thank you so much, and thank you for having me. So Richard, when you mentioned that 20% number, I tried to unpack it a little bit and think, what are the factors that are contributing to that? And I think there are a couple of things that come up that we can try to address from a policy angle. One is that we know we don't have a sufficient supply of clinicians who are providing substance use disorder treatment. Another is that we know that even where treatment is available, there are often a lot of other barriers that people with substance use disorders face in trying to access it. It could be distance. The nearest provider could be far too far away. It could be affordability. And so a couple of areas where we have an opportunity to address things from a policy standpoint are in increasing the supply of clinicians and trying to address some of those barriers. At HHS, there are a couple of department-wide strategies that we've developed to try to address this. We have an overdose prevention strategy in which increasing access to evidence-based treatment is one of our priority areas. Also, we put out last year an HHS roadmap for behavioral health integration, which aims to ensure that there is no wrong door for treatment. Behavioral health, including mental health and substance use disorders, and to make that accessible in any place where people are, bring treatment to them. There are a number of actions that we have taken under those strategies to try to improve the availability of treatment, which include regulatory changes. So as an example, SAMHSA in Part 8 rulemaking has proposed to make some of the flexibilities on how OTPs, opioid treatment programs, provide substance use disorder treatment permanent, including more flexibility for methadone take-home doses, more flexibility to initiate buprenorphine via telemedicine. And also we've made payment policy changes in our Medicare and Medicaid programs to make it easier for behavioral health specialists who are helping support a primary care team in delivering substance use disorder treatment can be adequately paid to make it easier for people to receive that care. But then I think there's another piece of that 20%, which is really important, which we don't focus on enough, which is that based on surveys, at any given time, most people who have a substance use disorder aren't seeking treatment. We have some real challenges in engaging people in treatment and also retaining people in treatment. And the surveys also give us a lot of insight as to why. People may believe treatment isn't effective. They may have other things going on in their life that are more pressing for them to identify, caregiving responsibilities, housing, employment issues. And also, we hear about pervasive stigma and mistrust of the healthcare system. So there are also, we believe, policy opportunities to address those. And part of the way that we as a department have proposed to do that is by embodying the principles of harm reduction, recovery support, and reducing stigma, and lifting those up as well in our overdose prevention strategy, and taking tangible actions to address them. Because I think, as Director Gupta pointed out, what we have seen is that if we can meet people where they are with compassion rather than judgment, and if we can offer them things that are important to them and that are valued by them, then we're more likely to have them remain engaged with us and eventually consider entering treatment. And at HHS, we've established the first harm reduction grants through SAMHSA to help do this, and also the first Federal Office of Recovery. So we're really excited to grow these activities and continue to support people getting the full spectrum of services.
Kyle?
I represent labor. As Richard said, I'm the Health and Safety Director and Members Assistance Program for a labor union in construction. And we realized a number of years ago that this epidemic was really, really prevalent in the construction world. And everybody was afraid to talk about it. And not in my backyard, I don't have that problem in my world, and they did. The way that this is moving, the advocacy that's out there, the people that are getting involved affects every worker, whether you're in a union or whether you're non-union. It affects every worker in this country, and it affects everyone's family. So over the past 8 years, the progression of advocacy has really taken off. And there are wonderful people doing all the work that needs to be done to remove the stigma that we talked about. We're going to talk about that in a little bit. But what that has done is it's opened up pathways for people to communicate about this issue, both on the labor and the management side. And what Dana's done in New Hampshire with his company is just a prime example of the two entities talking about this. And there are so many recovery-friendly workplaces out there right now that don't know they're recovery-friendly workplaces. If the management and labor get together and make a difference in somebody's life, that's recovery-friendly. And it doesn't have to be a formal effort. It doesn't have to be written in paper. It's just about caring. You know, I often am asked what our peers do. And what's it take to become a peer support person in the workplace? There's 3 things that they need to do. They need to be caring, compassionate, and concerned. That's it. Just care about your coworkers, their families. Listen actively, listen constructively, and come up and build a network and use it to get the people the help that they need.
I think one of the things that people will often say is businesses need the resources. A small business has a bunch of choices to make every single day on how they allocate their resources. So one of the things from a policy perspective is make those resources available to businesses to be able to use. The second thing is treat your employees holistically. Look at the whole employee, because we see very much mental health and substance use disorder hand in hand. And if you don't treat one, you're not treating the other. Right. And so if you look at your employees holistically, you get to have that picture and the compassion comes out.
Okay. Dr. Gupta sort of made a point that historically workplaces have often sort of represented punitive environments, if you will, particularly for people with substance use disorders, and especially those who might want to seek help. And what I'd like to do is drill down on that a little bit and talk about sort of concretely, sort of what do you guys do in your kind of everyday work life to sort of make the workplace sweep away sort of some of the punitive policies and procedures that have been there for a long time?
One of the first things we did, because our organization, I was actually shocked that I faced the amount of stigma within my own organization that I did through people that I'd worked with for years. I think you have to put the stake in the ground as a manager, as a business owner. You got to put that stake in the ground. You got to be public about it. Here's what we're doing. Here's why we're doing it. And, oh, by the way, this is the right thing and a good thing to do for our business. Here's why. And here's how we're going to do it. Admit that you don't have all the answers, because nobody has all the answers, but together we're going to figure it out. And then you begin to, I think bit by bit, it's a evolution, not a revolution. And you begin to evolve as an organization. You have to be true to your mission. You have to be true to what you say you're going to do, and then you have to go and execute on it. I think bringing in people who've had experience, have had lived experiences with substance use disorder, or people who have had businesses and had to deal with this, and what did you do? I often say some of my best ideas are stolen, right? Because I talk to other business owners and say, I don't have a policy for this. Business owners are great about trying to find a policy, right? I don't have a policy for this. Well, guess what? We're going to have to make one out. We're going to have to figure it out. So I think from an initial standpoint, you got to draw the line in the sand.
A lot of it has to do with education and awareness. And as a group, we've done really good with providing materials, providing things that you can take to your workplace and educate them on the problem. One thing that I came up with years ago was a saying, it's time to get uncomfortable. And this is a very uncomfortable topic to talk about. I call it lifestyle issues. Lifestyle issues in construction, addiction, suicide, and mental health. And I was finding that people didn't want to communicate about this. The stigma was there. They were going to lose their jobs. They didn't want to identify as having an issue. They didn't want to talk about their family problems. They didn't want to throw anybody under the bus in the workplace. And they were burying these issues. And you really have to develop a program and a culture where you start talking about the issues in a way that's going to benefit everybody. Now, I've been in the health and safety industry in construction since 1979, so I know a thing or two about culture change. When I got into the industry, the biggest problem we had was getting people wearing high visibility clothing, hard hats, and work shoes. That was a culture change. And then it went a little bit further in the 80s and 90s with looking at your job and how to do it safely. And now we're in the biggest culture change that industry's ever seen, and that is dealing with the lifestyle issues. And just being open about it, getting people to talk about it, getting comfortable talking about it. And people say, well, how do I do that? It's so hard. No, it's not. It's about learning to ask one single question and be prepared for the answer. Hey, how you doing? You okay? I notice you haven't been yourself. That's the most powerful question a worker can ask a coworker, because they're more than willing to open up to a coworker rather than management and owners. So now when they open up, the management staff and the owners have to be ready to provide them the answers that they need. And that's all a slow educational process, but it works. It works. I've had companies where I've started working with 5 years ago, they wouldn't let me talk to their workers about this issue. Now they're begging me to come to put on a presentation. They're doing it themselves. So that is moving the needle rapidly to people becoming workplace friendly and things along that line.
Let me just push you guys on there are two interesting lines you've drawn. Both of you have essentially talked about peers as being sort of critical. Mm-hmm. And there's a lot of talk both in policy circles and elsewhere about the role of peers. Now, things can go wrong if people give the wrong advice. And so I want you to say, is there training, is there socialization that needs to happen to really get sort of the peer models that you're kind of advancing to really work?
Yes. So let it be said that the alternative to have no discussion is far worse, right? So the alternative to have no discussion is much, much worse. But I also think that once you open your business up, once you open your organization up to have those conversations, guess what happens? You get better at having those conversations. And do you make some mistakes? Yes, you do. But you call upon the resources that you have, either professional resources around the area, whether they're recovery organizations or medical personnel, State of New Hampshire, recoveryfriendlyworkplace.com, State of New Hampshire. There's a wealth of resources from training perspective and things that businesses can get for free that they can look at and sort of build that culture. Our goal is not to be a recovery-friendly workplace. Our goal is to be an employee-friendly workplace, right? So we want to be in a position where we can have these conversations about anything. One of the things we've discovered, one of the big benefits was we found out we got better at having other discussions with people about their personal lives or about what was going on in their world. And that's a great thing. So we can, even if it's an uncomfortable conversation, you get better at it.
So as far as peer training goes, there's organizations out there that offer peer training, the Labor Assistance Professionals or LAP. They have a certified peer program for unions that want to get involved. And they do a wonderful job training peers. What you're seeing now is individual labor organizations doing their own in-house training, using evidence-based peer-type topics. One thing that my local did at a very early stage was contract with a licensed clinician and put them on retainer. So we have that professional umbrella over us to oversee our program. So everything that we do goes through the clinician. And that has brought a big sense of comfort to our union trustees that sit on the health and welfare funds and things along that line. So, you know, there are clinicians out there that are in tune with this, and they are willing to help employers and labor organizations to gain that peer concept and make it whole, make it work.
Do you want to weigh in here on where HHS is standing on peers?
Sure. I'll just say briefly that you know, we recognize, and it's a key part of our efforts, the tremendous value of the peer support workforce in recovery, and are definitely looking to identify ways to help support and bolster it. You know, I do think a key area that we've identified, you know, as important is to try to better understand and further support and develop the evidence base. To your question, Richard, about how best can we support and integrate peers into the workplace, identify places where you know, this has worked very successfully, and then disseminate those best practices, you know, to ensure that whether it's employers or other settings in which peers practice, that we can all really realize the benefits of this you know, really tremendous workforce that has the unique benefit of also having lived experience and expertise.
Okay, I'm going to switch gears a little bit. And this one starts with you, Tisa, which is, there was a question to Dr. Gupta about fentanyl. And, you know, the epidemic has evolved from one that was largely involving prescription opioids and has sort of really made fentanyl a central core of the problem. And how does this change, do you think, efforts to both address the epidemic broadly, but also what are the special concerns that you have to worry about in making sure that disadvantaged groups, low-wage employers really can sort of address the evolving epidemic?
Yeah, thank you. Yeah, so the rise of fentanyl has, to be plain, just made the problem a lot harder to address in a number of ways. And let me explain a little bit more why. So fentanyl is far more potent than prescription opioids and than heroin. You know, that means that exposure to fentanyl is more likely to more rapidly generate physiologic dependence and addiction. And people are more likely to suffer adverse consequences, such as overdose. But you know, another fact about fentanyl that is not often as appreciated is it's shorter acting. the effects don't last as long. And why does that matter? Well, what we've learned from a lot of surveys of people who use fentanyl, because in many parts of the country, fentanyl is actually replaced, the kind of local heroin supply, and so people might not even have much of a choice in terms of what they're exposed to. What we've learned from those experiences of people who have used fentanyl is that they tend to need to inject drugs more frequently in order to stave off really debilitating severe withdrawal symptoms. There's also some evidence that fentanyl can more quickly result in withdrawal and also more severe withdrawal symptoms when somebody's not using it regularly. I guess to give a concrete example, so a few years ago I heard a presentation by a community physician who was working in a community in Massachusetts where the local drug supply had pretty much been entirely replaced with fentanyl. She told me that she had patients in her practice who were injecting fentanyl as much as 25 times a day. Wow. in order to avoid debilitating withdrawal. 25 times a day. Now, pause and think, not only, is that just incredibly alarming in terms of how much it increases the odds that somebody overdoses, suffers a fatal complication or other non-fatal medical complications. But imagine what a challenge that is to somebody being able to work or do so many other things that are important to them. So I think that's a concrete example of how fentanyl has made this a lot harder. Now the good news is that we have effective treatments. Medications for opioid use disorder, methadone, buprenorphine, they work for people who have been exposed to fentanyl. But we are also learning that there can be some challenges sometimes in being able to initiate somebody on treatment. There are some reports that people may experience when they're initially starting on buprenorphine a higher risk of precipitated withdrawal. And so we have to adapt. We have to figure out, and I know the addiction medicine community is really hard at work on this, we have to kind of figure out how we adapt our protocols to keep up with the changing environment. But I'll also say I think fentanyl is not the only problem here. The other thing that we're seeing from the data is that many people who use opioids also use other substances. And so increasingly we're in an environment where use of multiple substances is common, and that also means that we have to make sure that our treatment strategies reflect that. In particular, we're very concerned by the growth in methamphetamine. Methamphetamine, while fentanyl accounts for the majority of fatal overdoses, methamphetamine is actually the category of drugs where we are seeing the most rapid increase in fatal overdoses, and we have fewer effective treatments for that, including no FDA-approved medications. So that is another issue that is really concerning, and that is getting harder. Again, we have to adapt. And then, Richard, to your question about disadvantaged communities, that is another statistic that we found very troubling, which is that there have always, unfortunately, been pervasive disparities in the negative impacts of substance use disorders, but they've been widening recently. And in particular, we're seeing that communities of color and economically disadvantaged communities are the most impacted. Also, face the greatest barriers in receiving treatment. And then finally, these also tend to be the same communities that face the biggest barriers, structural barriers in many other areas of life. Employment, for example, structural discrimination, racism. So with all of these kind of challenges stacking up, I think it's really important to make sure that we are prioritizing equity in our efforts and really holding ourselves accountable to not just addressing the problem overall, but making sure that we are doing so in an equitable manner and we're closing gaps. A couple kind of preliminary thoughts on how we can go about this. Well, one is we have to learn more. We have to constantly be reevaluating and updating our strategies to make sure that they are really meeting the changing crisis. But in particular, with fentanyl becoming so widespread, there is really a need to invest in more low-threshold treatments. Make it easier for somebody who is interested to get same-day treatment. There are a lot of promising models emerging for emergency departments, hospitals, bridge clinics, Understanding how we can scale those evidence-based programs up is really critical. And then making sure that we're really kind of intervening and focusing our efforts on the communities that are most impacted. Director Gupta had mentioned the really exciting historic announcement out of CMS yesterday about the new demonstration opportunity for states to offer Medicaid coverage for certain services up to 90 days pre-release. That's an example of how we can make progress in narrowing disparities as well. So those are a couple of things I'd point to.
Yes.
I really love Dr. Gupta's comment when he was talking about the fentanyl and the drug problem with, this isn't your grandmother's leafy substance that was being used. And one of the challenges that both labor and management has is getting the workforce to understand on a real grassroots level the problem that we're having with synthetic opioids. And I've come up with a moniker. One of the talks I was doing, guys were just kind of blowing it off, if you will. They weren't really paying attention. I said, look, guys, there's no more recreational drug use. And that statement hit an accord with the workplace. There is no more recreational drug use. Your lifestyle has to change. You can't go, camping or sit around a campfire anymore and go to your local drug supplier in the street and get cocaine or marijuana or anything because you don't know what's in it. And it's a one and done. There's no more even a path to addiction. If somebody wants to take a pain pill for back pain, and this has happened, one and done. Takes it at 5 o'clock in the afternoon and instead of 5:30 on the ground. That's the severity of this in the workplace.
I agree. I think that we often talk about when I was a youngster, eons ago, that there was very little you could do in your misspent youth that would kill you.
Kill you.
Right, the next time that you did it. That's not true anymore. Your next dose could be your last. You don't know where it comes from. You don't know what it's made of. And I think a big part of how we prepare for this is having these conversations and having the systems and support structure in place within businesses to be able to deal with whatever is the next thing that comes down the pike, because there's always a next thing. There's always a next thing. That's why if you build the infrastructure to be able to deal with it, then you adapt. That's why this is so critically important, to get the word out, to make sure that businesses know this is good for you, it's good for your business, it's good for your people. There's a reason why we do this, and it isn't just platitudes. There's a real positive impact, and there's a huge negative impact if you don't.
Yeah, I was just going to ask you guys, you look like you've been around for a while, and I wanted to hear, are you going to adapt? And you got to
Rub it in, don't you? You got to rub it in.
Beat me to it. Now, Dr. Gupta mentioned that the FDA recently approved naloxone for over-the-counter dispensing. And this is like one of a number of efforts to make naloxone more widely available. He made the point very nicely that it was sort of, a difference maker in the number of people who could be alive today if this were widely dispensed. So what can the employer do, like in the workplace, to make sure that you complement this new federal policy, and what other efforts can the government make as a complement to this sort of new over-the-counter effort to, in spirit, just do another thing to dispense naloxone more widely?
Well, the state of New Hampshire, we actually have naloxone in our business. We train all of our employees in the use of naloxone, and if they want some to put in their personal vehicles or take with them, as long as they've gone through the training, they're welcome to do it. The state provides it for us, and that's a phenomenal thing. We view it, our managers go through CPR training, they go through naloxone training, they go through, again, we go back to it's a health issue. And I honestly couldn't care less about the policy conversations around it. If it saves one life, that's all that I care about. We have a rule within our organization that if somebody hits the floor, I'm not going to try and figure out what the policy is, right? We want to make sure that we do whatever we can to help that individual, whether it's a CPR, whether it's naloxone, 911 gets called, but that's our policy. And so the more available this is, the better from my perspective. Now, is it ripe for misuse? Maybe. I don't care. Saves one life, it's worth it to me.
I agree. There's a big push in the construction industry now, entire construction industry, to have naloxone on every job site. And I agree 100%. And I was talking to a good friend of mine last night, Jeff Horowitz from Safe Projects, on the removal of the prescription for naloxone. And now you can get it over the counter. And it just came to me in an instant that I think it's good. I think it's good it's available without a prescription now, because it's removing the stigma of buying it. A lot of people were not going to their doctors and getting the prescriptions for it. Now, if you have it out there with your Tylenol, your Flonase, or whatever else, in a nice marketing campaign, hint, hint, you know, this could save somebody's life. They're maybe willing to pick it up at that price point, whatever it's set at, to have it at their house. And the other thing, too, is, you know, for people that aren't suffering or in crisis, you still got to have it, because your kids are coming over for parties. We were talking about this,
Right.
Dana and I were talking about this. You're going to have kids over your house if you have teenage kids or grandkids or whatever. You need to have that in your medicine cabinet, because you don't know what's going on in their lives.
It's
And
one
you could
dose.
have one dose.
Right.
You could have a situation where you need it. So the more we can get it out in the general public, I hope there's a day that we don't need it, but right now we need it. And we just went through training at our local union. We trained 40 people, and they're all getting their Narcan when I come back.
The state of New Hampshire offers training online for
Yeah.
how to administer
easy.
it, and it's really easy.
Tisa?
Well, we're incredibly excited by the FDA panel's decision, and think that, you know, to both of the points you raised, this presents tremendous opportunity, because it removes an important barrier to people being able to obtain naloxone. You know, people could pick it up in a wide range of retail settings. Once the over-the-counter version is available, you won't even need to necessarily go to a pharmacy anymore. You could potentially even purchase it online. So think about, you know, the opportunities that opens up for people to have this life-saving medication on hand. I think, you know, kind of few key areas of our focus. You know, so one, the FDA has encouraged the manufacturer to make the over-the-counter version available as quickly as possible and at an affordable price point. So affordability is something that we're very mindful of across our HHS programs. The Centers for Medicare and Medicaid Services, so state Medicaid programs can cover both over-the-counter and prescription naloxone, and CMS has encouraged state Medicaid programs to consider doing this. You know, otherwise the rules will vary by insurer, but we have encouraged insurers where possible to cover both over-the-counter and prescription versions while we're awaiting the final price point of the over-the-counter version. So those are some of the kind of efforts that we're focusing on as we're preparing for over-the-counter naloxone to become available. But the other thing I'll just mention is that, you know, we know at least right now that the large majority of naloxone that's in communities is not obtained, you know, through a pharmacy or a healthcare provider. It's distributed primarily by harm reduction organizations and other community-based organizations. Now, hopefully, with over-the-counter naloxone, you know, we'll see more kind of, you know, purchase. But you know, we recognize that the harm reduction and community-based organizations are incredibly important partners with this, and we want to continue to support their activities, because in addition to getting naloxone out there, they're engaging people who are using it, and they are a key conduit and partner to us in being able to make sure that, you know, those people are able to access other services that they need. So, keeping kind of, them in the game is really, really important, and we're, trying to support their efforts through, grant funding, through our SAMHSA grants, our CDC grants, and also, for example, through our SAMHSA SOAR grantees have had to develop, they've been required to develop, plans for how they are going to saturate their states with naloxone and really make sure that we get it out everywhere.
I couldn't agree more, because we leverage local organizations, SOS Recovery, who send somebody to us every week to sit in and just be available to our employees, but also help us with things like naloxone and training and peer counseling and knowing. People that are in recovery know when somebody's in trouble, a half a beat before we do, right? So that networking of resources and organization is just huge.
Yeah, I just want to pull a through line here that began with your opening salvo, Kyle, where you really sort of talked about sort of the union viewing this as a safety issue. You connected it early on to safety, and it's now come up a few times in a sense. You were talking about it as you don't care whether somebody hit the ground because of a heart attack or an overdose. Again, this is sort of a workplace safety issue in a sense. I want you to sort of pull on that thread a little bit.
Absolutely. It is a safety issue. Impaired workers is a huge problem, and it's starting to be recognized through OSHA, through NIOSH, with their total worker health program that's out there now. But how I looked at it as a safety issue was, I was sitting with a colleague of mine in the office one day, and I said, we're going to start talking about this stuff. We need a hook. And he looked at me and said, what do you mean we need a hook? We need something to grab their attention. Because if you get up and you just start talking about substance use disorders and suicide prevention and mental health, they're going to look at you, well, it's not my problem, I don't have that in my family, and walk away. But if you say it's a true safety issue and you equate it to what OSHA recognizes as the 4 leading causes of traumatic injury and fatalities, falls, caught in between, struck by, and electrical hazards, which have been around in that category since 1972, and you add lifestyle issues in on it, and you start to relate it to safety issues on the job site, in the workplace, people tend to listen. And they start recognizing that, yeah, this guy's impaired. He's going to hurt somebody. He's going to hurt me. He's going to hurt himself. And not only do the workers in the environment grasp that message, but the owners do too. The employers really grasp it. And they start taking action. And one of the things that came out of this whole looking at it as a safety issue is OSHA looking at this now to add it into their training programs through OTI. And they're working on that to get that done now. But NIOSH has done an incredible job with the Total Worker Health Program. And if you are a safety professional out there listening, please go to NIOSH's website and look up Total Worker Health, because it talks about everything that Tisamarie was talking about, and Dr. Gupta. You need to make this a holistic approach, to Dana's point, to solving the problem. And we're on the fringe of it now. And one thing that you can use to convince an employer or labor organization to get involved with this is, if you do the right thing, we'll do the right thing, and get people to pathway to help.
I think it becomes a safety and a performance issue, and you use the word impaired, and that's what our sort of baseline is this individual impaired? So we don't care how they're impaired at the moment. We want to know, are they impaired, and then we work through it from there. Right? And it becomes a performance issue for us as well. So it's performance and safety, because if you're impaired, you can't perform. And we want our employees to be able to perform, and we want them to be safe, and we want them to be healthy. We've just gone through the pandemic. We had to flip our company on its head twice, go remote, do things to protect and preserve. And I was scared to death that we were going to have problems, and we were going to have people who got really sick, and touch wood, we got through it. But I think the skills and the abilities we learn through that serve us well now to say we can do this. We can absolutely do this. And if you look at it from the perspective of a safety issue, you wouldn't let anything unsafe happen in your business. Right. You wouldn't knowingly let, broken glass be on the floor. So why would you not address this? We can do this.
Mm-hmm. Any addition to that?
Hard to follow that now.
All right, so I think we're going to try to take some questions from the audience. Okay, this one's from the online audience, and it's for Tisa. And it says, given the recognition that peer support programs can make a positive impact, is HHS working on creating guidelines for peer certification?
Thank you. So that's a terrific question. I'll say what we're doing as a department is trying to look very comprehensively about how we can help identify, support, and expand evidence-based peer support models. And that could include a number of different possibilities and levers. So that could include certifications or training standards, but in addition, guidelines about how to optimally integrate peers into different settings, and also critically we're thinking about reimbursement, which is this is important work that is very valued, and we should reflect that. So I'd say that we are kind of trying to address this as comprehensively and through as many angles as we possibly can.
Okay, the next question, actually, I'm really glad has been asked, and it's, I'm going to start with you, Dana, just because I know you have a story about this, which is, and the question is, recovery is often a multi-step process. Many employees do not respond, many employers do not recognize this and are not always willing to give second or third chances. I think your story is probably the best answer I can think of.
Yeah, we started off our whole journey. We never started out to be a recovery-friendly organization ever. Not at all. We had an employee who was a good employee in all respects, average employee, had a problem getting to work on time and being there all the time, which led to her dismissal eventually. Didn't think about it again. Fast forward 5 years later, got a phone call from this individual saying that I'd like to talk to you, I'd like to be considered for reemployment. And I said, well, typically when people are let go for not being reliable, that would kind of preclude them to be considered for reemployment, but thank you very much for asking. To which she said, no, wait, you don't understand. When I worked for you, I was hooked on heroin. And the British have a term for it, as I've said before, I was gobsmacked. I had no clue. And I had prided myself that I knew what was going on in my employees' lives. And she said that she wanted to be able to have the opportunity to talk to us to make amends. It was part of her recovery. And I said, well, come on in, we'll have a talk. Had a talk, spoke with her, interviewed her again, said, okay, make an executive decision, we'll bring you back. But you've used 10 of your 9 lives. Next day I go in, sit down with my management team and said, I'm going to bring this individual back in, and there was a mutiny on my hands. And this is the thing that was the most remarkable to me. Not the fact that this person had been hooked on heroin, not the fact this person had the guts to come back and ask for their job back, but the fact that people I'd worked with for a bunch of years were going, oh my God, you're not really going to do this, are you? And I got stigmatized right in my face. And we had to work through that. And in some cases, they were right. In some things, some issues they brought up, they were right. But in some issues they brought up, they were just dealing with stigma. So we had to deal with that. Now, we joke, and I'm sure that the folks at the office are watching right now, we call ourselves the home for second chances, right? Because, and sometimes it's third and fourth and fifth chances, because that's the way it works. So, again, we try and put the yardstick of how would I want my wife, my daughter, my granddaughter to be treated in this situation? What would I expect? How would I like them to be treated? And are we treating these people in that manner? and that's what we do.
You know, I think back about stories that I've been involved with personally from our membership that were absolute incredible recovery stories. People that were living in their cars, destitute, going through treatment programs 3, 4, 5 times, and finally seeing the light and getting it, and them going back to work. And I'll tell you one brief story because it's really relevant and it's current. 7 years ago, we had an operator in a tough situation. He was holding a load over a highway, and he was under the influence of opioid, and he nodded out. And the superintendent on the job had to throw rocks at the window to wake him up and get him out of the cab. And he said, here's your chance. You go get the help that you need through the union, and we'll take you back to work. And he did. And he worked hard at it. He continues to work hard at it. And today, as we speak, he is in Denmark learning how to run the largest crane that's coming to the East Coast to assemble wind towers. That's a success story. And there's thousands of them out there, hundreds of thousands of them out there. And people need to embrace that. We do not want to lose any more valued employees. We want to give everybody a chance to work. We want to give everybody a chance to be healthy and happy at work. And we can do it by continuing to fight the fight.
So let me build on that a little bit because I just got a question about that, related to that, which is Americans don't do return to work programs all that well.
No.
Whereas Europe seems to be a bit ahead of us. What would you suggest we sort of start to try to institutionalize in terms of getting people back to work? And, you know, unions are kind of in that business a lot, and so I thought I'd start with you, Kyle.
Yeah, organized labor as a whole, and this is all aspects of organized labor, has done well, so to speak, to embrace recovery-friendly workplaces, to bring them back, to be supportive. You know, you can go through the list of AFL-CIO affiliates, and I would guarantee you 98% have some type of program to help members that are struggling. So I think what we just need to do is get that message out there, expand it a little bit, promote recovery-friendly workplaces, get more people involved, on board, and truly get labor and management working even better.
I agree, and I think a big part of recovery is for both the employer and the employee to be accountable.
Right.
So return to work from our point of view, for example, if you've suffered a relapse is a part of recovery. If you've suffered a relapse and you identify it to us, you're eligible for rehire provided you've gone through the program, but conditioned upon a return to work agreement, right?
Yeah.
And I think that's fair. So there's a fairness test that says what's fair to the employee, what's fair to the employer. Here are the conditions under which you can return to work. And I agree, it's not been prevalent. Nowhere prior in my work history and ever have I had to deal with it. But today it's a functional part of what we do, which says, are you willing, and for me, I'm more interested, are you willing to sign up for that? Because if you're not willing to sign the piece of paper, then you're not willing to invest in yourself.
Perfect.
And that's what we're all about.
And we don't have 100% success rate.
You don't.
Trust me.
Nope.
Not at all. And you know, that gets back to the saying, you do the right thing, we'll do the right thing.
Right.
There comes a point in time, and it's the hardest thing that peers have to do, or employers have to do, or union representatives have to do, and that's cut somebody loose. Because it's being toxic to the rest of their workplace environment.
Correct.
But there are situations that happens.
Right.
Richard, if I make a suggestion to my friends as well, Also, employee health benefits and employer-sponsored insurance. There's a real opportunity there to make sure that people also have access to the full spectrum of treatment and harm reduction and recovery supports that they need to help kind of facilitate their full participation in the workplace. I'm sure you're both all over that already,
So
but
do
I got to throw it out.
Do you have any good contacts in the insurance industry?
Comment.
Because that's where a lot of stumbling blocks come from. Insurance companies not paying what they should be paying.
That's frustrating, but you figure it out. Where there's a will, there's a way. So,
Especially for peer programs and aftercare.
Right.
Recovery coaches, we got to get the payers on board with supporting it, because recovery doesn't happen in 28 days. It's a long-term process, up to a year or more, and people need that support, depending on what their own private support is at home. But if you're not having a good experience re-entering into the workplace, into your home place, relapse could come at an alarming rate. So we need to take that support system and grow it once they come out from evidence-based treatment, and make it a long-term program. So that's what we got to work on.
Sounds good.
So what you've seen here today so far is the vanguard of the first adopters. And one of the questions that came in made the observation, well, let's not forget that 10% of the deaths are workplace deaths. From 10% of the workplace deaths are opioid-related deaths. And that means that, part of it, you're never going to go to zero, but that's still a lot. And the question is, while you guys are out there doing the good work, there are many who are trailing the convoy here.
Right.
And how do we sort of engage more employers, more organized labor, although it sounds like they're pretty much in on this.
There's work to be done.
But what is the work that needs to be done, and what would you suggest we do to really sort of spread what you've demonstrated to us today?
part of the reality of why we've become so interested in recovery-friendly workplaces is there's this huge labor shortage, right? And there's a whole universe of people who have been excluded from the workforce because they either have a felony or they had some sort of prior addiction problem. Being a recovery-friendly workplace has meant that we have individuals that come in the interview and say, it's the first time I haven't had to lie on a resume. We can have these conversations. We work with the drug courts. We work with the drug court in Stratford County, New Hampshire, is one of the best in the country. We work with probation and parole. We work with these recovery organizations. But I think getting the word out and talking to people, I offer myself up as often as I can. If you want to talk about it, give me a call. Because I think if you hear from another business owner, because I get it, I get what your fears are, I get what your stigma is, I get what your trepidation is, but let me tell you, the difference between my business and your business is I know the people who are suffering from substance use disorder and you don't. That's the difference. We have programs in place to be able to deal with this. We can help them, we can identify them, and in some cases, do they need to leave? Yes, they do. Some cases, they do. But at least we put a program in place that will allow us to address it. But we need more forums to be able to get to the businesses. And we need resources and policies in place because I think a lot of businesses think this is going to be expensive and time-consuming to deal with. And it doesn't have to be.
And I think you're starting to see the research world starting to change a little bit and looking into these issues. A lot of my network is built upon collaborations between researchers, advocates, and these conversations are starting to talk. I was just at the Working Minds Summit in Kansas City, and that seemed to be the overlying
Right.
theme. We need to do more to get the involvement. 'Cause, you know, 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 ' 8 years ago, it wasn't there. We were still defining the problems. We were still really at the tip of the iceberg. Now that we've drilled down a lot, and you're getting larger construction companies involved, you're getting larger employers involved in industry, you're starting to see a change now on where the research and academics are going with this from grant research, which is great, because now we can start getting the tools that we need to affect change at my level and Dana's level.
Okay, we're coming to the end, and I promised that I'd give each of you a parting shot, but one of our questions came in and said, in your parting shot, could you answer the question of what's giving you hope? So why don't we start with Tisa?
All right. I guess I have several thoughts that I'll end with. So I think the first is that one thing that does make this particularly challenging is that we know that the substance use disorder crisis is layered on top of and reflects and is exacerbated by so many other structural factors outside of just the healthcare system, and housing affordability, criminal justice, barriers, other structural barriers to employment. All of these things are converging. They're also converging and stacking in a way that is harming some communities more than others. And we have to, I think, center and address that in our efforts. And that's something that we at HHS are really trying to do, is trying to really lead with equity. But because this is such a complex and multifaceted problem, we know we can't do that on our own. And so I'm thrilled because, for the longest time, previous to coming into this job, I was a practicing primary care physician. Sometimes it felt like, we're the kind of medical system, out kind of trying to deal with this, but, we need other folks to partner with us. And I can see that we have wonderful partners, which is incredible, and we really do need to all kind of, work together, because a complex problem like this requires a coordinated, multi-sectoral response to really address it. Even we can't do it alone, right? We need others to kind of come and join us in this. I think that is one thing. The second thing I will say that I think has at least helped us at HHS a lot in our policy development, and that I think is so critical to developing effective policies in this space, is to learn from, center, and amplify the voices of people with lived experience of substance use disorder, and really value their expertise and use it to design better policies. We also believe that by amplifying their voices and lifting them up, we can kind of help together to address stigma. I'm hearing that that's what both of you have done in your programs, and so that's wonderful. And I think that's something that we want to try to, replicate, amplify, and build on. And then I will say that the thing that gives me hope is that while this is a challenging problem, and while it is changing, and we have to really, run faster and faster and faster to keep up with it and adapt, I believe it is one that we can solve, because we see that recovery is possible. We see that people thrive after recovery, and while it's tough to tackle, think even just in the past year of all the really significant policy changes that we have seen that have been so many years in the making. Removal of the X waiver, naloxone, certain naloxone formulations being approved for over-the-counter use. Now, people who are incarcerated, their states have the option of covering some of their services in Medicaid before release. We've made a number of changes to payment policies across our HHS insurance programs to address this. So there has been a steady march of policy changes to address this. We know there's a lot more to do, but what gives me hope is that I'm seeing that steady drumbeat, and I'm seeing change happen, and we're seeing things move forward, and we just got to keep going.
Kyle?
What gives me hope is here I am sitting at the Brookings Institute. I never envisioned being here. Again, thank you very much. But, you know, all the people that are out there doing the work, that really have a passion for this work, I've been blessed to really develop relationships with these people. And I look at our own union, 3,000 members, active members, and I look at what the people that work in the peer support program there does. And one thing that we did, we thought out of the box a number of years ago with the clinician on retainer. His name is Jerry, and my assistant coordinator of the program, Ashley, came up with this model of family support night for our members. And we just kind of said, yeah, let's give it a try. And those two individuals took that model and ran with it. And here we are probably 7 years later, and another one of our fellows that is a certified peer support person and works for a larger construction company, Sean. The three of those run this program every Thursday night from 6 to 7. And we have 25 to 30 people and come in there consistently from the community, from other labor unions, from other, you know, working environments to talk about these issues. So those are things that give me hope that the smallest little thing can grow into something beautiful and help so many people. And that's where recovery-friendly workplaces came from. And the employers are getting it. My hat's off to employers across this country and Canada, because you're doing the work that needs to be done, whether you know it or not. So that's what gives me hope.
Good.
What
Dana?
gives me hope? There are several things. State of New Hampshire Recovery-Friendly Workplace started in 2016, grassroots. Handful of recovery-friendly advisors. Now there are 30 states that have adopted some form of recovery-friendly workplace. That's just astounding that you can get 30 states, 60% of the country, to do anything, right? So that's pretty amazing. And the transfer of knowledge and the conversations that go every time we get to talk to these people is just astounding, and that gives me hope. Recovery-friendly advisors in the state of New Hampshire, there's a handful of I'm going to date myself, there's a handful of women that are amazing. We couldn't do what we do without them, and they're the glue that holds the whole thing together. So definitely want to make sure that we recognize them. The team that I have at our organization, our team, is just amazing. They've kind of wrapped their arms around this and ran with it, and they do yeoman's work, and that gives me hope, because not only I'm convinced that I have the fortitude to do whatever I need to do, but can you transfer that knowledge and that passion to somebody else? And finally, within our organization, there are we have people who came in through the drug court program. My director of sales came through the drug court program, right? So he's just a shining example of what it is, what it's all about, what we're all about. And finally, I know personally several people that are alive today because of what we did. Period. Guaranteed. It doesn't get any better than that, right? It doesn't get any better than that. So that's what gives me hope. There's a whole, that you see a family, you see an employee who's lost everything, get an apartment, get their family back, get to see their kids, get their car. It's all basic stuff we all mostly take for granted.
Yeah.
That's where the hope comes from.
Okay, well, we're just about out of time. And in closing, I want to tell you what gives me hope is that we have leadership at the top and leadership all the way down the line that cares so deeply and is willing to work so hard on these problems. So thank you to Julie. Thank you to Dr. Gupta. Thank you to these three fabulous panelists. And I want to thank all those who attended, both here in the room and online. And a special thank you to the Brookings events and AV staff that always do a wonderful job and always make it so that this thing actually comes off and comes off the way it does. A recording of this event is available or will be available on YouTube and on the Brookings website. And you can follow our work on behavioral health by going to the Brookings website, www.brookings.edu. And thanks all, and
Thank you.
onward.
Thank you.